Virginia. Mr. Griffith, 5 minutes for questions, please.
Thank you very much, Mr. Chairman. HRSA does not require all covered entities to provide evidence that they have taken corrective action and are in compliance with program requirements prior to closing an audit. Instead, HRSA generally relies on each covered entity to self-attest that all audit findings have been addressed and that the entity came into compliance with the 340B program requirements. Ms. Draper, does HRSA re-audit a covered entity after a corrective action plan is submitted to ensure compliance before they close the audit?
They don't before they close an audit, but they have conducted 21 re-audits over the course of I don't know, a couple years. So, in the findings of those, one, they found a covered entity, one of the audits, where the entity did not implement their corrective action plan, as they said. They found 12 other instances where the non-compliance findings were similar. 3 were for the exact same issue. So, even in the re-audits, they find, that, audits probably should not have been closed.
And so wouldn't it be a better practice if they would at least do a mini audit or something to make sure that the problems were addressed before they just close the audit and say, here are your problems, but we're not coming back to check on you,
Or require some kind of documentation. At GAO, it's a very similar process. We don't close a recommendation unless we have specific documentation that something has actually been implemented. A lot of times, an agency will submit to us that they have a plan. Well, a plan doesn't do it. It has to be actually implemented. So I think, more rigorous information that they require from the covered entities as to what they've done.
I would agree with that. And I know that some of the hospitals are, saying that they use the, I'm switching gears on you, but they use the monies that they generate or that they get from using the 340B program to help somehow. But I noticed that about half of the covered entities that you all reviewed, the uninsured patient discounts just didn't go to the patient. And I know they may be using it somewhere else, but don't you think that's a little bit of a problem, that we ought to have some way to track that to see that it's at least going to help folks who are low income?
Yeah, so what we found of the 55, so we sent out 55 respondents that responded to our questionnaire. 30 said that they provide discounts at some or all of their contract pharmacies. 25 said they did not, but of those, 4 actually provided discounts in their in-house pharmacies, and then some others talked about that they provide benefits through like their charity care program that may cover
and I get that. I just think that since we're putting this program out, we ought to have some way to track that to make sure. In fact,
yeah, there are no requirements for discounts, that the program provide discounts.
Right,
so.
And I noticed that on page 32 of your report, you all found that some patients are even required to cover the cost of a 340B dispensing fee. So not only are they maybe not getting the benefit, but then they're having to take money out of their pocket to pay the contract pharmacy a dispensing fee. Should Congress establish a new policy prohibiting that practice?
Well, I think, so what we did find was some of the contract pharmacies said that if a patient is uninsured or low income, that they would discount that fee or just eliminate it altogether. So there's a wide range. It's hard to make generalizations because we saw so much variation in how these arrangements worked and the financial arrangements. So it's just,
But I will tell you, it troubles me when I see that we've put the program together to make it less expensive for folks, and then we find that through the process, in some places, they're actually charging these folks a dispensing fee. That troubles me.
Well, you certainly don't want to discourage people from getting the drugs that they need.
Exactly. Looking at my various questions as my time runs out, do you think that, or what would the effect be of limiting to fair market value the fees a contract pharmacy could charge a covered entity? That is, what if HRSA were to take the profit motive away from contract pharmacies and ensure that the benefits of the program would actually flow to the covered entities and not the contract pharmacies?
Yeah, that's a really difficult question. I think the issue. I
try not to ask all the easy ones.
That you don't want to create negative incentives that the program doesn't work as intended, and I think that So it's hard to make a blanket generalization because I think some of these things really do require further look-see to see what the impact actually is.
All right, and I think that's fair, and I appreciate your time and your testimony here today and appreciate it, and thank you very much, and I yield back.
Chair, thanks, gentlemen.